Evening, everyone. I'm just giving it a few more minutes for the last people to join. But however, I'd like to thank you all for joining us this evening. My name is Dr. Mareshi Mahlangu. I am the Chief Medical Officer of Clinics Group. Um, I was away for the past 2 weeks, and I do know you were in the good hands of Dr. Kanoshi, and I am back on this week. So for today, just some housekeeping rules. Once again, everyone keep your mics muted unless we request you to unmute your mic to specifically ask a question if we don't get clarity in your written questions. Please go ahead and put your questions in the chat box below. And at the end of the presentations, we'll go through all of your questions. So for tonight's guest, I have Dr. Comfort Fakude. He is a senior registrar at Steve Biko Academic Hospital, having completed his FC ophthalmology examinations, and is currently finalizing his MMed dissertation under the mentorship of Prof. Makunyani at the University of Pretoria. He is an active member of both of the Ophthalmologic Society of South Africa and the South African Vitreoretinal Surgeons. Dr. Fakude participates in cataract outreach programs across the country, serving as a surgeon for the South African National Council of the Blind. He is currently completing a retina rotation at Steve Biko Academic Hospital, where he plays a vital role in the ophthalmology academic program. His responsibilities include teaching both undergraduate medical students and postgraduate sports medicine students at the University of Pretoria. In addition, he regularly contributes to ophthalmology departmental academic meetings and is dedicated to training junior registrars in various surgical skills, including corneal transplants, cataract surgery, retinal surgery, oculoplastics, and strabismus surgery. So I'd like to welcome this evening our guest of Dr. Fakude, who will be giving us a talk on diabetic eye diseases. Over to you, Doc, and thank you and welcome. Doc,
Thank you very
yeah, there
much.
you go.
Thank you very much for that lovely welcome. And yes, I'm happy to be here to share with you this vast topic called diabetic eye diseases. As you know, that diabetes as a disease is quite extensive in its pathology and also how it affects our people everywhere. And uh, so let's get into it. This is the outline. It's quite a, don't be stressed about it. You're gonna go very fast on it and let's see how we go. We're gonna look at the anatomy of the eye. We're gonna look at the ophthalmic complications of diabetes, retinal vascular diseases, diabetes epidemiology, associated risk factors to develop diabetes mellitus, pathogenesis of diabetes mellitus, ophthalmic complications of diabetes, diabetic retinopathy, risk factors for diabetic retinopathy, pathogenesis of diabetic retinopathy, and clinical presentation of diabetic retinopathy, and classification of diabetic retinopathy, neovascular glaucoma in diabetes, and also peripheral diabetic retinopathy treatment, diabetic macular edema, indications for vitrectomy, and other diabetic eye diseases, and cover some treatment. So now, looking at the eye, anterior to posterior, we might not necessarily cover it in that manner, but let's go for it. Let's see. Just to mention that the eye is quite a wonderful organ. It's very small, but yet full of diverse function, all the way from the front of the eye, or just the tissues that cover it, etc. You know, looking at the structure, it just shows how the eye would is sitting right in the center or in the front of the face, next to the sinuses, next to the lacrimal gland. You know, it plays a vital role. A human being can't function properly without vision, you know, and proper function of vision. And you know, so it's very important for us to understand that it's just a structure to show also another view of the eye, how it sits next to the sinuses, the muscles, the nerve, and the optic chiasma, the orbit itself. So this is what we are looking at. There's also another diagram that illustrates its blood supply, nerve supply, associated cavernous sinuses. So it's a beautiful structure, so complex and yet beautiful in its nature. If we're to look at the lacrimal system, it pretty much lacrimal drainage system. It will cover the eyelids. It's not just for beauty where ladies they just do their eyelashes and all that, but it's because the eyelashes themselves they contain what we call meibomian glands that produce the oil that is part of the tear film, which is important in refraction of the eye, of light to enter the eye. So that's why we find that in some patients who have a problem with the tear film or dysfunction of the lacrimal drainage system, a patient would be happy, they can't see very well, the eyes feel like there's foreign body sensation. There's a whole host. Others have infection of the drainage system, like maybe the nasolacrimal duct. So a lot of things can go wrong in the eye. But remember, not to get carried away, we're talking about diabetes. So here it is. You can see how tears are produced from the lacrimal gland, maybe the aqueous part of tears, and drainage through the nasolacrimal duct into the nose. That's why when you cry, you have a runny nose because the tears, the aqueous from the lacrimal gland is drained that way. And we also have in front, or now talking about the globe itself, the front part is the cornea. It has 5 layers. We're not going to go through them. But we also know that the cornea itself, it is supplied by the trigeminal nerve. I'm speaking about this because we're talking about diabetes, that it is a disease that almost affects every part of the body. So it will also affect the cornea at some point. We might talk about it. Just anyway, the question, we'll talk about it because I might not have a full slide on everything that we have to do with diabetes and the eye. You can see its blood supply, how complex it is, encircling the eye, giving blood flow, giving even nutrition, giving warmth to eyelids themselves. Maybe the previous slide that shows the eyelids, there is blood supply to the eyelids themselves, And so it's very important for us to understand the anatomy. For anything in medicine, anatomy is quite important. This is just another part diagram that shows the angle of the eye, the cornea in front, the iris and the cornea where they meet, we call it the angle. So it's quite important also to know that there's an angle because we're going to talk about neovascular glaucoma, which affects exactly that part of the eye, So, and also below the eye, below the lens, we'll find the vitreous body, which is the transparent gel that fills about the 5/6 of the volume of the eye. It is clear. It has different attachments in the eye itself to support the eye so the eye doesn't just go flat. So it has its particular importance that it is 98% water. It must be clear for us to transmit, for it to transmit the light all the way from the cornea, from outside, tear film, cornea, lens, vitreous, all the way to the clear or the transparent retina, and into the brain, the information is taken. So this is quite important to know. And in diabetes, quite important to know. The orbit in oculoplastics or in some diseases that affect the orbit, is very important for us to know other structures that affect, that are involved with just the globe. Now this will go back to the back of the eye. We have the retina. Even if you have a beautiful cornea, beautiful lens, beautiful iris, whatever color you wish, but if you have a crappy retina, you can't appreciate the vision. We have children with ROP, so it's they have damaged retinas, but the eyes look beautiful. So with the eye, it's a whole host of many structures that must function in harmony with each other so that light can be converted from the outside to the inside and absorbed and taken to the brain for interpretation. And then a person can have a good life. They can appreciate beauty, look at their loved ones, go places, you know what I'm saying. So this is just the eye as it is. It's a beautiful structure itself, the retina. It has 10 layers that have different functions, and diabetes definitely affect the retina quite a lot. So So these are some of the slides I'll go through quickly because I'm trying to rush so that we can please get to the meat of the discussion because there's a lot of information I've got for you there. So the retina, I'm just going to pass through it. Maybe the important part that at the center, at the back of the eye, there's the optic nerve and the macula. The macular luther, which is the spot where maximum distinction of vision is found, where the maximum concentration of cones for us to appreciate color, that someone is wearing something purple, blue, yellow, whatsoever. It is the fovea. And right at the center of the macular luther is the fovea centralis. So this is important to know all these structures, how they are formed and how they receive blood supply, etc. So this is some of the things that we're going to talk about, just to remind you, because all of us, I think we have done a bit of eye anatomy at medical school. If not, this is just a crash course on it. Just knowing just a little bit on the retina, that it receives two blood supply. The choroidal circulation, that supplies about a third of the retina. The outer third, the back of the retina, and then we've got the retinal circulation that it supplies the 2/3 of the retina from the central retinal artery. So this is very important as well to talk about it. Anyway, so this is just part of some other anatomical structures that you can find in some of the books. There's the choroid, rich blood supply. The choroid is part of the uvea, which covers all the way from the iris, the ciliary body, and the choroid. It nourishes the layers of the retina with its blood volume. It conducts many blood volume forward. It conducts the blood volume forward to the anterior regions of the eye. So it's quite beautiful how it functions. And we're talking about diabetes mellitus. So it's very important to know all these things. The sclera, which covers the globes and to protect it, and etc., etc. But this is just a brief overview of how the eye looks like from looking at a person from the front. You look at the eyelids, and there's also the cornea, the conjunctiva, the sclera, the lens, the iris, the ciliary body, the vitreous humor, the retina, the choroid, the optic nerve. That's how it is. Beautiful structure. And just now talking about a whole host of, so under retinal vascular diseases, you find something called diabetic retinopathy, which is the disease of our time. It's a disease of our time. Maybe you'll understand as we start with this thing. Look at epidemiology. I was reading this. It says now, 2021, the report of the IDF, which is the International Diabetes Federation, they said approximately 537 million individuals globally are affected by diabetes, which was about 10.5% of the world's population. That was 2021. Now we're at 2024, So you can imagine how many people that is between the ages of 20 to 79 years. So now, this costs about $966 billion in healthcare. Times that by our rand, maybe we're crawling in big numbers here. This is worldwide expenditure, probably even worse in our time. The projections indicate a surge in diabetes cases to 783 million by the year 2045, which is not that far off, So that will be about 12.2%. So the statistics are going higher and higher, which will cost about $1,054 billion to take care of the disease. So now this is what they say: almost a half of that 537 of all people with diabetes are unaware of their medical condition. So it's possible that right in this platform, there could be someone who has diabetes mellitus and they are not aware of it. Recently, a cousin of mine was just diagnosed with diabetes. He had presented with high sugars. He had to be admitted. He didn't know. He was having fun, enjoying life and doing his thing, and landed up in hospital, So this is very important for us to take ourselves very serious and look at it and take care of ourselves by the way we eat, the way we do things, so you can tell that the highest prevalence of undiagnosed diabetes is found in low and middle economic countries. So that we will cover definitely South Africa, Africa per se, but also because we are more westernized in a sense. So definitely we are right there on top. I think the other day my wife was telling me that no, man, uh, um, they say diabetes is the #1 cause of death in women in South Africa. That's in South Africa. So can you imagine that? She was listening to on radio. So very important for us to take care of ourselves. These are just the projections of what I was talking about, how it was affecting people. And now by the year 2045, there will be about 783 million people with diabetes mellitus as a disease. So now, what are the associated risk factors to develop diabetes mellitus? So this increase. The prevalence of diabetes increases in populations whose lifestyles have changed from more traditional to modern forms of living. I guess if you look at us, the way we used to live, or our parents used to walk, they used to eat more natural food, not refined food. They were eating, they were walking. There was more activity. Look at us, we are sitting. You know what I'm saying? We're sitting, we eat fast foods and all those things. So pretty much I'm just explaining what it means about tradition to modern lifestyle. High correlation with overweight, obesity, a high BMI, growing age, being old itself is a risk factor. Family history, ethnicity, we know that is quite common in some populations, and a whole host of genetic factors are involved. Obviously, dietary foods, and there's also environmental and occupational stress. We are definitely stressed as an occupation, as doctors or healthcare sector. We are dealing with massive people suffering from different ailments. We are stressed. We are losing patients from this or that. For us, we are losing patients as well in ophthalmology with different diseases. We know these are the things that we are suffering from. Tobacco usage, insufficient physical exercise. We're not talking about walking around. We're talking about an intentional way to exercise. So we can look at that reference there if you want more information. So diabetes is a chronic metabolic disorder caused by defects in insulin secretion and action, characterized by sustained hyperglycemia. The eyes, because we're looking at diabetic eye diseases, the eyes are often indicators of systemic disease and are particularly vulnerable to the pathophysiological changes that occur as a result of diabetes. This we know, we've been taught how it's diagnosed, fasting glucose versus random glucose, and there's tests that can be done, and also looking at HbA1c. Then there's classification where insulin-dependent diabetes is younger patients than 30, and non-insulin dependent or type 2 is those who are older. So pretty much those are just the basics of undergraduate. When we were doing undergraduate degree, we were taught extensively about that. Now, looking at ophthalmic complications of diabetes. Now, just in the eye, but now we're going to talk about other complications. Look at common ones in the eye that people will develop: retinopathy. They'll develop iridopathy and unstable refraction. Under retinopathy, we're talking about diabetic macular edema, the swelling of the macula. If it's swollen, therefore light is not properly transmitted into the brain for proper interpretation. Macular ischemia, there's no blood flow or supply to the macula itself. And later on, from retinal ischemia, there's the development of new vessels, there's vitreous hemorrhage and tractional retinal detachment. And we can just talk about unstable refraction. Maybe we'll come to it. Why is it that someone who's diabetic, suddenly they can't see very well at a point in time? I can't see very well now. And obviously the healthcare professional is worried now. Might wanna be tempted to send the patient to an ophthalmologist for proper assessment. But nevertheless, the uncommon things that happen is recurrent styles, xanthelisma, we talk about accelerated age-related cataract, we talk about neovascular glaucoma. All these are complications of diabetes. Oculomotor nerve palsies, reduced corneal sensitivity. We did mention that in as much as someone will have a diabetic foot, even in the eye, you can have a cornea that is affected by diabetes, because now the diabetes has affected the trigeminal nerve, the supply of sensation to the cornea, And also rare, we can talk about the other ones that are mentioned there at the bottom. Talk about now papillopathy, light near decision defects. We'll talk about progressive optic atrophy. We're going to talk about acute onset cataract. We're going to talk about rhino-orbital mucormycosis. So this is very important for us to understand diabetes is going to kill us and will kill our people and going to make us very miserable. So it's very important for us to get a hang of it and to be in control of it as a discipline. That means the healthcare professionals. Diabetic retinopathy. The prevalence, looking at what Kansky, one of our books, says now, is about 40%. You know, for those who have diabetes. So 40% of those roughly will have diabetic retinopathy, and more common in type 1 than in type 2. You know, so sight-threatening disease is present in up to 10% of diabetics. So at 10, so if you have 100 people, 10 of them will probably lose vision. You know, sight-threatening, at least that's what it says. You know, if I guess we intervene, we do something as a healthcare professional, we can stop that. You know, so we have proliferative diabetic retinopathy affect about 5 to 10% of the diabetic population. Type 1 diabetes mellitus are at particular risk with the incidence of up to 90% diabetic retinopathy after 30 years. It's almost guaranteed when you have type 1 that you're going to have diabetic retinopathy. But there's still that 10%. They must be doing something right, or the health professional is doing something right for those people. Anyway, so looking at this, the risk factors for diabetic retinopathy. What are they? What will make you to have a retinopathy because of diabetes? The duration of diabetes is very important. It is the most important risk factor. Patient diagnosed with diabetes before the age of 30, that means it will be type 1, have about 50% incidence of diabetic retinopathy after 10 years, and 90%, as I've just mentioned, after 30 years. Diabetic retinopathy it really develops within 5 years of the onset of diabetes itself, or before puberty. But remember, we have said by the time people are present to you, 50% of that number, of 587%, they don't know that they have diabetes. So it could be, you could be having it for the past 2 years, eating up your blood vessels and your nerves. By the time you land to the doctor, you're at casualty, you're in DKA or honk state, which hyperosmolar, you know, a state of hyperglycemia. So it's very important for us to develop a culture of checking ourselves even as professionals. Duration is a strong predictor for proliferative diabetic retinopathy than for maculopathy. So just looking at that, how it, because you can have that, retinopathy, or you can just have diabetic maculopathy without, like, where it just affects the macula itself. The rest of the retina, yes, still has it, but not as much, and person will be miserable from that. Type 1 diabetes are at particular risk to develop it, as we've mentioned. So the risk factors are the duration of the disease, those who have type 1 diabetes mellitus, those who have poor metabolic control, those who are pregnant, those who have hypertension with diabetes, those who have a nephropathy, and other risk factors. But let's go back so we can at least go in detail about diabetic control. Blood control, but diabetic control and complication trial, the DCCT. So they say in this study, tight blood glucose control, particularly when started early, can prevent, maybe that's what is important, can prevent or delay the development or progression of diabetes retinopathy. This is also confirmed by the United Kingdom study itself. So it's very important that as GPs or physicians, we must make sure we tightly control. And we're not just alone doing this, we must involve the nutritionists as well. You know, must send the patients as well. We need to see this physiotherapy so that they can exercise them, or given proper exercises and given skills, how those people can, or those patients can be able to lose weight and all that stuff. So it's very important to talk about losing weight in diabetes. And also sudden improvement, also another point about poor metabolic control. So if sudden improvement in control was associated with progression in the short term. So now let's say you have diabetic retinopathy, and now we are spooked as a physician. Now you want to tightly control it very quickly. That has been associated in the short term with a progression, but then it also stops at some point. It regresses a bit. But it's very important that when we start the control, we it gradual. When suddenly now patient was running in the 20s, now we want to bring him around 6 HDT level. That's not good advice, at least from the studies. Type 1, they obtain greater benefit from good control than in type 2. So the patient, if they have a raised HbA1c, this is associated with an increased risk. It's obvious because we do this HbA1c test that looks at the control for the past 3 months. So it's so a high level definitely is a risk for proliferative diabetic retinopathy. Therefore, aim for values that are very low. Though the diagnosis thereof is that we will diagnose with diabetes if your HbA1c is more than 6.5. But nevertheless, once you have it, you must make tight control of this disease among, as health professionals. So now, another point that we must know is that decrease of 1% in HbA1c is associated with a third reduction in microvascular complication. So it's very important, therefore, to also look at the numbers themselves, and aim for better control and improvement of lifestyle of our patients. Pregnancy is also another risk factor that we must talk about. Just a minute here. This is associated if someone is diabetic and they become pregnant. This will cause a rapid progression, and therefore the predicting factors include a greater pre-pregnancy severity of the retinopathy. So if the patient is already at a state, a worse classification of the diabetic retinopathy, once they have diabetes, they're going to be worse. This massive high volume in diabetes doesn't work on their behalf, So control exerts to another risk factor in diabetes that makes it worse if your control is exerted too rapid during the early stages of the pregnancy, and also people who have preeclampsia, of course, So it's very important for us to know this thing. The risk of progression is related to the severity of the diabetic retinopathy in the first trimester. So now, if you find yourself already you are severe non-proliferative diabetic retinopathy, once you become pregnant, you're going to progress very quickly during pregnancy. So it's very important that people, before they plan their pregnancy, I think I remember this when I was still at Baragwana, that when they plan their pregnancy, you make sure you get good control of their diabetes, so that when they get pregnant, you still maintain that control. It's very good for your patients like that. Diabetes macular edema usually resolves spontaneously after pregnancy, though so those who develop it late, diabetic macular edema, we have patients that are referred to us who have poor vision, and you see the macula is swollen. If these develop later in the pregnancy, you don't have to treat it. It will resolve by itself. Now, also people who are hypertensive, it's very important that we get rigorous control of the blood pressure, less than those now, the 140/80. So it's very important that when a patient is diabetic, let's properly control them. Already the diabetes is going to affect blood vessels. The hypertension also worsens the issues. So tight control, particularly beneficial in type 2, with maculopathy. So also people who have cardiovascular disease and previous strokes are also a predictive, something that is also a risk factor. Also patients who have the nephropathy, disease of the kidneys. If severe, it is associated with the worsening of diabetic retinopathy. So treating renal disease, actually, when your patient get a renal transplant, actually, it's associated with improvement of retinopathy. So, so we must therefore be able to see how we can intervene and help our patients, and also once the patient gets the renal transplant, when we do a laser of the retina, it responds even better, interesting enough. Other risk factors, we know that being obese, we know what they've seen, metabolic syndrome X, talk about hyperlipidemia. These are the things that when we're obese already, we have high cholesterol, we have high blood pressure, these are all risk factors, that can worsen diabetes already. Cataract surgery, when we operate your cataract when you're diabetic, your vision, the retinopathy can be worse because of the surgery itself. So it's like a catch-22. What are you going to do? Going to leave the patient blind or going to operate? So that's what it is. So it's It is a terrible thing to have the disease, but once we have it, we can therefore try our best to control it. But even better to prevent it by eating right, doing the right things as a people. So now, looking at, so the pathogenesis, obviously, we know that it is affects small vessels. And because of this high sugar, and I was reading the book by L Pathology by Ralph Eagle, who was saying hyperglycemia causes apoptosis of the pericytes. That means the cells that surround those small blood vessels, they die, so causing a microaneurysm, causes leakage. So there's no more support of the blood vessels, just the sugar itself being high, so high, it causes sudden death of those cells. So it's a bad idea to have a high sugar level. Anyway, so it affects precapillary arterioles. We know that pretty much, and that in the end, it's you are leaking everywhere, yet someone can't see where you are leaking from because all this leaking is happening inside your eye, inside your body. So consequently, consequently, we get now areas of the brain of the retina where there's a retinal capillary non-perfusion. There's no blood flow. The retina is not getting nutrition, so it dies. So when it dies, then we get now a coping mechanism from the body, from the retina. Now we call IRMA, which is now the intraretinal macular aneurysm. So abnormal formation of connections between now the arterioles and the venules. So now there's improper connections there because we're trying to make sure we're stealing blood. Now the body is stealing blood from the arteries to the venules. So on also another thing, neovascularization, new vessels are formed because now the retina is starved. It feels that by being starved, it must have more pipes now. There's not enough water coming through. You think by installing more pipes is going to solve the situation. And that makes things worse in diabetes. We don't want more pipes for water. We just want to make sure that the houses that are not getting enough water, they're wasting water or water is not enough. Let's just remove them from the network of water supply. That's how we solve the problem in diabetes. Anyway, so pretty much that is a vicious cycle. We have poor diet, we get diabetes. At some point, the vessels are damaged. Until now, there's no more blood flow because there's clogging up of the blood vessels, they die, and then there's retinal hypoxia, then causes ischemia. That ischemia triggers what we call vascular endothelial growth factors. We're forming now new it's almost like now creating RDPs in the retina, not proper houses, proper vessels. And now that is the problem that the ophthalmologist is faced with to deal with these new vessels that are going to cause a havoc of consequences for the patient, ultimately translates to blindness, and the patient is miserable. And another burden for patients to be sent back to the psychologist and the psychiatrist for different problems. You know what I'm saying? From vision itself, from a diet, from the plate, from the supermarket, what we buy, and the lack of physical activity. How from one thing to the next, your life is changed like that. Anyway, so just looking again, this is how in the end it will present this disease in the eye, microaneurysms, hemorrhages, exudates, cotton wool spots, which are spots that are looking like cotton wool, macular edema, venous bleeding, all these changes that you find. So now there's a classification for those who are interested, probably ophthalmologists, where we classify it, the new ETDRS classification, where we split the retinopathy in the eye to be non-proliferative versus proliferative. So whereby in the non-proliferative, we can have no diabetic retinopathy at all, so nothing needs to be done, or we can have very mild, moderate, severe, and very severe. So this is based on how we see. So it's very mild, just microaneurysms. Already means you have had episodes of high sugars that had killed the pericytes, and now your small vessels have become aneurysmic. So mild is when we have microaneurysm and some small retinal hemorrhages, exudates, and cotton wool spots. Moderate is when now you have retinal hemorrhage in about 1 to 3 quadrants, and the rest of it, and also have venous bleeding, rather say. So now the severe one is when we have a 4-to-1 rule, where the severe hemorrhage in all 4 quadrants, it pretty much is like a bleeding eye. It's a bleeding eye, that's waiting just to jump into a proliferative state. Very severe is when you also have, they just classify the same thing, that 2 or more of the criteria for severe non-proliferative. Anyway, so now we also have another classification where, or we talk about proliferative parts. So now when you have jumped from this state to this one, now you find now this proliferation means that there's new vessels, can be mild to moderate, high risk, and advanced diabetic eye diseases. When mild to moderate is when we have new vessels at the disc, or elsewhere, but the extent is insufficient to meet a high risk criteria. What is this high risk criteria? Is when we have a new vessel's disease equal or greater than 1/3 of the disc diameter. So when you look with your in the direct ophthalmoscope, you can see there's vessels there about a third of the disc. Or if you see there's any new vessels, then there's also blood. You can't see very well with the direct ophthalmoscope. I'm talking about direct ophthalmoscope because it is a skill that all we must have. So we know what we are referring. You can't just, not everybody who has a diabetes has a problem in that needs to be checked by the ophthalmologist. So it's very important for us to know how to use this. It's quite a beautiful thing to learn that. Anyway, the other last stage is advanced diabetic eye disease, where we talk about now fractional retinal detachment, significant vitreous hemorrhage, and urobiosis iridis, when there's new blood vessels on the iris itself. Now, the advanced diabetic eye disease will cover hemorrhage, fractional retinal detachment, and rubiosis iridis. I'm just going to jump here, but we can pretty much here in these 3 stages is that when a patient will come with a hemorrhage that is inside the gel, which is the vitreous body, and usually takes longer to clear, in this thing. And you'll find that the person can't see. Sometimes, can't see very well because there's just new vessels that are leaking now and causing bleeding inside the eye. Or we can have fractional retinal detachment, whereby now, because of the vitreous attachment naturally in the eye, now because there's bleeding, now there's contraction and pulling of the retina from the different areas because of these fibrotic changes and the bleeding as it resolved. So the last one is when we have rubiosis iridis, because now the retina is ischemic in these different parts and there's new vessels forming. Now part of those VEGF, vascular endothelial growth factors, they deposit into the iris. Now the iris starts having new vessels that clog up the angle of the eye, therefore affecting drainage of aqueous out of the eye, causing what we call neovascular glaucoma. Anyway, so this is how an eye would look like. So a patient like this probably would need agent laser for the new vessels. So pretty much we are killing the peripheral retina so that we can maximize blood flow. There are people who are already dying. People say, I'm just making a figure of speech here. People already dying, they're right hanging by a thread, but we're still giving them food. Let's cut off, let them die. So we burn the peripheral retina and maximize the ones who are going to survive. It's almost like the trial system, how it was developed, anyway, indirectly, vice versa, rather. Anyway, so this is what it is. So now neovascular glaucoma, so when now the angle is clogged up, the pressure goes up, so it's a very serious predicament to solve the problem when things are like this. But nevertheless, it is the challenge, I guess, to the ophthalmologist. So neovascular glaucoma, as a complication of diabetes, now it occurs as a result of severe iris vessels, and then clogs. We've spoken already about that and how we're going to solve that problem. So this is what we'll do. We can do PRP, which we can burn the rest of you can see that picture there, where we're burning the rest of the unwanted or a dying retina, so that the retina doesn't keep on thinking that I need to make more pipes for blood flow. So we'll make sure that whatever little blood is available is maximized on vision. So we can do that. And so we can also part of that proliferative diabetic retinopathy, we can do PRP, we can do vitrectomy, or we can give injections like anti-VEGF stuff, which is drugs that are available to us, So that's that. So now proliferative diabetic retinopathy treatment will involve maybe doing laser, which is a very good treatment standard. But though we know with the advent of anti-VEGF now, we can use those. Obviously cost quite a lot of money for patients, especially those who can afford. So we find ourselves in a predicament. And also, as some part of treatment, we talk about vitrectomy, and there are studies that look also at the benefit as well of the use of anti-VEGFs treatments. So now also part of that, we speak of diabetic macular edema as a separate entity, because now you might find that the rest of the retina is fine, but the macula itself is involved. How do we solve that? Very important to make sure that patient gets good control of diabetes, lifestyle changes, modify risk factors for progression. We can do argon laser, as part of the treatment. We can also do injections, anti-veg. We can do periocular and intraocular steroids. We can do steroid implants and vitrectomy. Here's some of the things that are there. We talk about different studies that are shown where we talk about the DRCR, read, write. We talk about anti-veg drugs that are very effective, like bevacizumab, ranibizumab, aflibercept, all these new drugs. We even talk about newer drugs like faricimab, that are used, or brolucizumab, that are used to sort of dry up the retina, because it is the swelling. It's like the same thing in CCF, where if a patient has CCF, they can't breathe. Even in us, we use these drugs to dry up the retina, just like we use Lasix to drain the water from the lungs so the patient can breathe better. So now we use these anti-veg apps to sort of help the retina see better, or the vision to be maximized on the macula. So that's what we focus on. So now these are some of the studies. I will just go quickly on that, because it's quite a lengthy presentation, but there's different protocols that we can look at. So where we do laser, different type of laser that we can just to focus on the maculopathy. We can do grid laser. We can do injections. These are different techniques that we can employ in ophthalmology. And also we can even do intravitreal triamcinolone, which is just a steroid to help calm down the inflammatory part of that. And also do vitrectomy itself, so that if in case there's a pulling of the vitreous, or there's membranes pulling, they want to release that, so the retina or the macula can relax, and so it can go back to its natural position and do its proper job, not swollen, dry, if we can call it that. So indications for vitrectomy are this one, where we have vitreous hemorrhage, this severe progressive TRD or combined TRD, and rhegmatogenous retinal detachment. Rhegmatogenous retinal detachment is when, because of the pulling of the tractions of the retina, also it causes a hole in the retina, and the fluid seeps into that space and creates a predicament for us to solve the problem. But nevertheless, that's the field that we've chosen, and we must able to deal with it. So there's also when we have blood, because it's sitting right in front of the macula, and so we must deal with it and do some operation. These are just part of the pictures that you can see in diabetic eye disease. So really, from a beautiful eye that we've had, and you find yourself now with an eye that is full of problems with hemorrhages, traction, diabetes, cataract, etc., etc. So these are some of the procedures we can do. NDEAG, for if there's the hemorrhage that is sitting right in front of the retina, and you can do NDEAG laser, and just to disrupt that. You can see in picture C how that is resolved by doing NDEAG laser. And now this is just the last video that I want to share with you, so that, I don't know, just to show you what we do.
This is a 36-year-old diabetic with a traction retinal detachment that progressed to a traction and rhegmatogenous retinal detachment. The intervention was done with 27-gauge vitrectomy. As you can see, the very small vitrectomy probe can get under tissue, and we're here performing blunt dissection to separate the tissue. It is very efficient in cutting these very thick fibrovascular membranes from the surface of the retina. Here we're using the 27-gauge forceps to remove this little stalk from the optic nerve. We're injecting perfluorocarbon liquid to flatten the retina over the optic nerve. After this is performed, this aids us in removing some of the peripheral fibrovascular tissue. Aspiration of subretinal fluid is performed with the vitrectomy probe through the pre-existing break. Residual fibrovascular tissue is dissected slowly, being shaved by the 27-gauge probe. Subretinal fluid is aspirated and the retina is flattened at the same time that a fluid-air exchange is performed. Perfluoropropane gas is left as a tamponade, and argon laser is applied to the peripheral breaks. This is the post-op picture.
Okay, as you can see, that's a very nice surgery. But anyway, we'll just to show you what vitrectomy would look like. You know, how we flatten the retina, we remove the traction band. That's a very, it's an okay eye, that one we are looking at. The eyes can truly be worse, eh? They can truly be terrible and difficult to solve. Some we just say, hey, mommy or dad, we can't do anything. We just can't touch your eye. Now you just had hand movement or light perception. If I touch it, it's like I'm switching off the light bulb. So that's how terrible it can affect us. Other diabetic eye disease, I'm going to go quickly as I wrap up this presentation. We talk about now papillopathy, where we can have a swollen, bilateral swelling of the optic disc. Obvious in this case, you must be able to exclusion of raised intracranial pressure. We can do opening pressures, etc. You know the protocol for that. But the eyes, the optic nerve could be swollen, and it's very important to make sure that you exclude raised intracranial pressure. Cataract themselves, we've spoken about them. Quite a common, they're quite ulcerated in diabetes mellitus. The hyperglycemia is a high glucose. Because of the high glucose in the aqueous, so what it does is the aqueous, the sugar diffuses into the lens, and then the sugar is converted to sorbitol. And because of the sorbitol, now it's a solute. Now water is poured into the lens, then the lens is overhydrated, and patient becomes myopic, short-sightedness. So it could be that we've spoken a little bit about that. That patient could be now can't see far, but now they can see close. Or sometimes we find that there's cortical fluid vacuoles, like a little bit of spots there full of water that affects the patient's vision, and that can progress quickly to cataracts in some time, in a short space of time, and patient can have accelerated cataract in, especially the young generation or the young people. And also even nuclear opacities are common and tend to progress more rapid than age-related macular nuclear sclerosis. It was very important to know that. We also have third nerve pulses. We know in diabetes that it spares the outer pupillary nerve fibers. But once the pupillary fibers are involved, that's why it's an emergency, because we know probably there's pupillary fibers that are normally outside are being squashed or pressed by an aneurysm. So that's why it's a neurosurgery kind of protocol or intervention. But it's very important to know that not just one nerve, many nerves can be involved. We spoke about the trigeminal nerve, where you can have neurotrophic ulcer. The eye is not getting enough supply, so the patient can't blink. We need sensation for the eye to be able to produce tears and all that stuff. So diabetes, just like a diabetic foot, can't feel. He can just walk into the fire and burn his leg. But even in the eye, the cornea is literally, you can touch it with your finger because there's no sensation. So that is a problem. To treat it, we must give lots of lubricants. That's probably our space, but nevertheless, we must know that. It's just to remind you of how complex the eye is. Other diseases, you can have a Horner syndrome in the diabetes. You can have bilateral light near dissociation, not just Igel-Robinson syndrome only, but also diabetes can affect that. So it's literally can affect anything you can think about. That's diabetes for you. So another one, maybe not beautiful, but serious to know, is this one called muco or rhinomucormycosis, a rhinoorbital mucormycosis, whereby a patient who presents with the cellulitis and is diabetic, if it comes in DKA with proptosis, it is mucormycosis until proven otherwise. And it is an emergency because this patient can die, die in a short space of time. For this patient, they said he died 10 days after photo was taken. So it's a very serious condition. It's very important for us to know these things and make sure our patients, they know that whatever disease they have, it's quite important, and they must take care of themselves, eat right, exercise, lose weight. Those are very important. Even ourselves as doctors, we probably, as health professionals, we need to lose some weight because it doesn't display a good picture to encourage our patients. But nevertheless, it's not necessarily for that. It's good for ourselves as a people to be healthy, to live long, to take care of our grandchildren, to see them. You know what I'm saying? There are a lot of benefits to these things, not just that. So anyway, a patient will present with this condition, with the diplopia, periorbital swelling, but normally this is a gradual onset. But nevertheless, once they are there, they're diabetic, you must better make sure that you check it. They're not in DKA, test their urine, do blood gas and all that stuff, and involve the other discipline. In ophthalmology, you will then refer a patient to internal medicine for that, but as well, we're also checking the eye. But mostly the patient will die if not properly treated. So now this is part of differential diagnosis of an acutely inflamed orbit is, you can see it's quite a lot, but nevertheless, the acidosis will probably kill the patient, but also the septicemia from the fungus and bacterial superimposed bacterial infection is quite terrible for these patients. This will see this asher black tissue because of the fungus itself. Now, treatment, probably the last slides, that treatment of diabetes in general, patient education, educate. They must comply to treatment. They must stick to their reviews. They must be involved counseling, weight reduction programs, diabetic control, and we must make sure we control their blood, their hypertension. They talk about phenylfibrinate, which is 200 milligram. It showed some improvement in some patients. Despite them taking a statin already. So we must stop smoking. Also, we must address other things like renal failure and anemia. So a patient with diabetes already comes with a risk of even other diseases. So it's very important as well that we must involve, as ophthalmologists, other disciplines. We must work as a team, involve the nutritionists, we must involve the physiotherapists, we must involve the physician, we must, what I mean, based on what the patient is suffering from. Anyway, that's the end of my presentation. I was trying to rush for time. And thank you. These are my references. I hope you've learned something. Thank you very much.
Thank you. Thank you so very much, Doc. Other than it being information overload, I must say this was a highly informational talk today. We have sure learned so much today. So I'm going to start with the first of our questions. And the first one comes from Faith, who says, why is diabetic retinopathy more common in type 1 diabetes than type 2?
It's probably because of the duration thereof. Because you remember, we spoke about duration to be a very important risk factor for the development of diabetic retinopathy. So if you are already diagnosed to be type 1, that means you have already gotten this disease earlier on in your life. So you have more mileage with the disease. And if not controlled, because remember, because people are banking, so when you're young, you can sort of get away with a lot of no MIs, etc., but it's still damaging your eyes. Simple answer is that mileage, you have more time with the disease, therefore more time to cause damages in the eyes.
Thank you. So it's all about mileage, Faith. In a diabetic who develops early cataracts, but the vision is still okay, and this is from Devanand, is there an indication to do cataract removal and lens replacement?
It's all about the patient, eh? If the patient wants the surgery and it affects them somehow based on their job, maybe they need better vision, they are truck drivers, and therefore the requirement is that they must have 6/6 vision both eyes, then it will be necessary to do them. But if it's an old granny who doesn't really care about good vision, she can still read her Bible and she's happy with it, there is no need for us to rush it, because remember, I've mentioned that the cataract surgery itself can worsen, can worsen diabetic retinopathy. Even there's complications of cataract surgery itself. So it is not necessary. It is necessary when the patient really feels that it's affecting their lifestyle. Thank you.
Thank you for that, because, and I think that goes back to something that I've noticed over the years, that the patients that are getting cataract surgery are getting younger and younger. Especially in the private sector, we're finding 35-year-olds, 34-year-olds having, cataract surgery. And I would assume that that also then speaks to the prevalence of diabetes that we have growing within the community. And that's good to know that you're not forced to get the cataract surgery unless it starts affecting your activities of daily living. Next question is, in the management of DME, what reasons are there to use steroid implants despite the risk of increased glaucoma formation vs starting? Oh, sorry. Sorry, Ona. honor REANX9. My apologies. Let me start this again. I get what you're saying now. In the management of DME, what reasons are there to use steroid implants, which I would assume the likes of Ozurdex, despite the risk of increased glaucoma formation versus starting on anti-VEGFs?
I guess this is a discussion that a patient must have with the ophthalmologist. Yes, it's a good point that not everybody who uses steroids will develop glaucoma, responsive glaucoma, or they were not steroid responders, unless it's been known that that patient is a steroid responder, then it's a better idea to do that. But we have newer drugs now. Maybe if you can read about faricimab, which is also an anti-VEGF that focuses on VGFs and then the angiotensin 2, I think, pathway, which are quite brilliant. They are good. So really, I think at this point in time, we do have a whole host of evidence that shows that the anti-VEGFs, we have a whole host of them that show really good improvement. And also, we must look at the patient themselves. What disease do they have? The question is sometimes maybe, I think if it's a patient naive treatment, I think the use of anti-VEGF is a good idea, not to use steroids first. You know what I'm saying? I think we jump into steroids when we feel like we have used the anti-VEGF and there's no improvement. Then let's try the steroid implants. That would make sense to me, not just start on the steroid implants same time.
So now this is going to go into Honor's question and also for me. So considering the fact that the anti-VEGF, there's been a new development in there. So would you then say a patient should then be started on maybe a Avastin and then you escalate into your other molecules of your anti-VEGFs, and then you save your steroid implants as your last line?
That would be one approach, definitely. I think even okay, now because we're talking private things, even the medical aids themselves, they won't just, I think probably they will want to find out, why do you want to now start on this? Have you tried the steroids? Have you tried the anti-VEGF like bevacizumab, ranibizumab, or aflibercept, whichever is available for us, But I'm saying there's even newer kids on the block like brolucizumab. They're quite effective, especially in patients who have not responded to Avastin. When you bring them brolucizumab, there's good effect on them. Yes, they have their own side effects that we must take, intraocular inflammation, but there's this new kid in the block, Vabysmo, that is quite good because it caters both the two pathways there, and has been quite effective recently. So I think it's something that we must look at. That would be the approach. Start with the anti-VEGFs that are there, and if you have tried them and you see there's no improvement, you can just directly go there, unless you probably can motivate for whatever reason. But this is a discussion that we probably going to have with the medical aids. But I think generally you're going to start with the anti-VEGFs and then probably move to the steroids. But I think now we have a new kid on the block like the faricimab that I think they say it all sort of covers that steroid pathway, but not in that sense of using the steroid implants per se.
Thank you. So then I guess this then answers Honor's question, which says, what treatment regime is superior in the management of DME? Treat and extend, which is pro-retinata, or fixed treatment date?
I think now they're speaking about treat and extend. That's what.
Yes. So would you treat and extend with your anti-VEG, or would you have a fixed end treatment date?
No, I think so. Treat and extend. Yeah. But must also read also the newer drugs, the newer things that I have spoken about. I think now it's more where to treat and extend. There's loading doses that you will give like for 3 months or so, and from there you keep looking and watching the OCTs and see if there's changes and treat per requirement. That's the new thing now in the industry that's happening now. You don't just now just keep giving. You must look. Is there changing? And if you don't see any changes, you treat according to the response. But now the newer drugs like ranibizumab, those drugs, they focusing on treat and extend.
Right. So now leading into the next question is that the last statistics that came out is that 79% of African women in South Africa are actually overweight and obese, which then speaks to what your wife picked up is that many women now suffer from diabetes. So the question that we have from one of our participants today, okay, Honor REA, you have so many questions, but I don't have your name. It just mentions your phone, is that with the global diabetes prevalence increases, are we seeing the same with increased DME rates?
I'm not sure. I wouldn't be, but I think I would, I don't know. But I would assume, therefore, that based on what we've just presented on in terms of duration, risk for developing diabetic retinopathy, if you have it for longer, uncontrolled, and that will then predispose you to the development of those diabetic retinopathy. So the more people we get, it will go without saying the disease, it's what it is. If you have the disease for more than 5 years, then it poses a risk for you to develop diabetic retinopathy because it's a disease that affects small blood vessels. So the natural progression of the disease will take place. The more the people are affected, the graph will also follow the same trend. Unless obviously there's a new thing developing. But I think that's how I would say it. I don't have a direct study on that, but I think that's what I would say.
All right. So I think it goes back to what you say is mileage.
Yes, mileage.
Mileage. All right. So someone earlier asked a question on that about the exudates and which are caused by the microvascular leakage. And cotton wool spots are infects in the nerve fiber. And Duracin are yellow deposits onto the retina, right? So now Faith has asked, how would you tell the difference on the retina between the different types of exudates? I don't know if you have a picture of that again.
Yes. Is it the question that was asking about what's the difference between exudates, drusen,
Yes, it's the questions
and,
about what's the
and
difference
cotton wool
between what
spots?
the exudates are, and then now they're asking, how would you tell them? How would you tell the difference on the retina?
How, like in terms of when you fundoscopy? Okay, now because let me just answer the question, it doesn't matter. So drusenoid material, when you look into the eye, let's start with drusen, which is an AMD term that we use. So a patient who has AMD, age-related macular degeneration, will have drusenoid, which are deposits of drusenoid material below the RPE. So it's a further low, deeper behind the RPE, in that interspace. And on OCT, you will see a corrugated RPE or basal membrane that is damaged by the drusenoid material. In that, because there's a damage of that interface. So drusenoid are much deeper and they're yellow. So there's different grades, therefore types. There's small, medium, and large. But nevertheless, it will be a bilateral condition. They won't have any of those. The person won't have diabetes, I guess. Let's assume. This is just a typical patient who has AMD without diabetes. But nevertheless, a diabetic person will also have microaneurysms, hemorrhages, and then we have so now exudates now are found in the retina itself. So which could be hard exudates, which is leaking of lipids into within the layers of the retina themselves. So deeper layers, almost like a dot and blot hemorrhages in the deeper layers of the retina. And they could be hard, which is like discrete. So there's a way of describing that discrete in size, they're deeper within the layers. And now when we talk about cotton wool spots, more nerve fiber layer ischemia. So now those are more superficial. So they're fluffy. They're like cotton wool. Cotton wool, if you look at it, it's white. So cotton wool spots are described based on their appearance. When you look at it, it looks white and fluffy, the indistinct margins. Whereas hard exudates, they're more deeper layers, but they're also discrete. It could be white, and that's more describes leakage of. You see, like it's more of a chronic state whereby because of the constant leakage of lipids in the retina, then they harden up, and that's what they are called. But drusenoid is much even further back behind the RPE as we call them drusenoid. So that will show nicely on OCT. So I guess the drusenol is easy because a typical patient who without diabetes will have drusenoid material. The other two, we can describe them in diabetes, but though obviously we probably could still find cotinous spots in conditions that will cause ischemia of the nerve fiber layer. I don't know if I'm making any sense to the patient, to the doctor.
I think it makes sense for now. So we've got Dr. Muhuddin who asks, is there any benefit of ocular exercises?
Yes, I'm sure those who need it, there is benefit to it. What are they trying to accomplish? Yes, actually, there is benefit to them because you are training just like you go to the gym and you're training yourself, person as a. Actually, maybe we should ask as physiotherapists there and say, is there benefit of exercising to them? Yes, there is benefit to them. That would be the simple answer. We
My
speak
next question,
and we recommend them, yes.
still recommend them. The next question is there still a space for laser photocoagulations with so many VEGs now, with
Oh,
so
yes.
many educational?
Oh yes, oh yes, oh yes. That the answer will say, oh yes. In public sector where we don't have, it's easy maybe for people who have medical aids, and then we can go back and forth with discussing and motivating for drugs. These are expensive drugs. A vial could easily be 8,000. A drug of this small thing that you're gonna inject into the eye. An old gogo who's pension and we must burden that, in the public sector, taxpayer, it's a problem. So laser pen retinal photocoagulation is still a gold standard for patients who don't have resources or who can't come for follow-ups, because something like a follow-up, it costs money. People, they get irritable. You keep telling them, come today and come next week. For me, I just write it because that's what it says in the book, or because I want to see you next week, I'm worried about something, but it costs money. So PRP is like something that we can do for a particular set of people, and obviously we can discuss with the patients. Yes, those who can afford, yes, we'll try the newer drugs, and because they can afford them. But at some point, even those newer drugs might not work. We might still default back to PRP. So it is still used, it's still available. It's not just used only for diabetes as well, but also used also for other conditions. But nevertheless, that's a simple answer. It's still necessary and it's quite important.
Right, that's great. Oh wow, you seem to be very popular today. Next question we have is management of floaters. How do you manage floaters? And is that even associated with diabetic ocular disease?
Uh, there are people who are probably floaters without any disease, because it's age-related thing. It's just like a deposition of calcium oxalate and different kinds of minerals in the system. Which it might not affect visual acuity, so we don't have to do anything. But remember, the patient is key. Is like in a restaurant, they say the patient, the customer is always right. Uh, not necessarily maybe in the public sector, but if it affects the patient, you keep, now it's causing you to want to be psychotic now because you see something moving and you want to hit it, maybe think it's a bee, you know what I'm saying? Maybe for that reason, for that reason alone, we can do a very extensive procedure, which is a pars plana vitrectomy to remove all the vitreous and leave water. So that's the only way we can solve that. But it's not necessary for us to do anything if it's not affecting your vision. Simple answer.
Thank you. Oh, actually, thank you, Faith. This is also a very important question. And in my another life, when I was a GP in GP practice, this is a question we would get because even optometrists, according to patients, are eye doctors. So the question is, during early stage of DR, when would you refer to an ophthalmologist versus when would you refer to an optometrist?
I think as soon as a person is diagnosed with diabetes mellitus, it is very important for us to remember. I said that 240 million people in the world, they have diabetes, yet they don't know about it. So now
Yes.
it's very important, therefore, for us to say if this patient is diabetic, don't you think it's a good idea to find out how much damage is there? Even if we're gonna come with a clean slate, say, oh, all things are good, see you in 1 year. Remember, we say you see in 1 year because we're trying to figure out, is your sugar controlled or not? Because if it's not controlled, forget about duration time. If your sugar is always buzzing in the high levels there, you're gonna progress very quickly. So that's very important. And you find that you're already not eating right, you have other comorbidities like hypertension, etc. So I would advise, it is very important, as soon as you know diabetic, refer them. We have a baseline test to check for cataracts, check for everything. You know what I'm saying? You don't know what you could be dealing with here. So I would advise them to see ophthalmologist and we have a baseline fundus score. Unless you have a fundus camera, obviously, you can take a picture and check that there's nothing there. And but nevertheless, I think it's very important to have a baseline test to check that everything's fine.
Thank you. Thank you, Doc. So I'm going to request the audience that please, as usual, email us the rest of your questions that you have, and we'll send them through to Doc, and we'll email them out to everyone who attended today. But I want to thank everyone for participating in tonight's webinar, and especially you, Dr. Fakude, for giving us such a wonderful presentation on diabetic eye disease, and considering how important it is in today's age with the prevalence of diabetes increasing. We'll probably get you back to deal with the slides that you didn't have time to spend time on. But I just want to say to everybody, thank you so much for joining us tonight. And thank you, Doc, for joining us tonight. And I wish everyone a good night. And this is goodbye from me at Clinics. Thank you, everyone.
Thank you. Thank you very much. Thank you for the invitation.